10 years ago, showing the prevalence of daytime sleepiness. It was a telephone interview where they gave people something called the Epworth Sleepiness Scale. And a score of more than 10 means that these people were very sleepy. As you can see, 32% of residents in Mexico City are too sleepy. 32% are too sleepy. This is, by the way, interestingly, the same sort of ratio as we see in other countries. So the prevalence of daytime sleepiness is very high, no matter where we go across multiple cultures in industrialized societies. And about 12% said that this interferes with their daily activities and interferes with their work. So this is a problem not only that exists in high proportion, but also interferes with people's ability to function. Now, we know that daytime sleepiness has a number of negative effects on mental functioning. So, daytime sleepiness produces slow response time, impairs our ability to have memory, it reduces our learning, and reduces our concentration. These are very important in areas where we deal with in psychiatry. For example, in psychotherapy. When we do psychotherapy, it's important for our patients to remember what we talk about. In addition, many of our patients with psychiatric syndromes report diminished memory, report diminished understanding, and in many cases, these are due to daytime sleepiness, which we have not identified correctly, unfortunately. Daytime sleepiness has been linked to a number of catastrophes. The Challenger accident, the 3 Mile Island meltdown, and many airplane accidents as well. Here's an interesting video. Can you turn this on, please? It's a video showing a trucking accident linked to daytime sleepiness. I think I can keep this. There we go. This is a video of a truck traveling down the highway. And pay attention to this truck as it begins to swerve to the left, as the driver begins to fall asleep. Here's another video of a car accident. Oops. Turn this off, please. So, these are dramatic examples of how sleepiness can interfere with our functioning, but of course it's also important to know that sleepiness can be subtle, but can also interfere with the functioning of our minds on a day-to-day basis. These are data from a medical setting looking at medical residents and interns who were sleep-deprived versus those who were not sleep-deprived. Notice the ones who were sleep-deprived were twice more likely to make mistakes while reading electrocardiograms compared to those who were not sleep-deprived. So to doctors, to physicians, sleep deprivation, shift work, is an important negative cause of our being unable to function correctly, which in turn translates to detriment on the part of our own patients. We know also that sleepiness leads to problems not only in cognitive functioning, but to physical well-being. Sleepiness increases pain sensitivity. It increases depressed mood. It also aggravates hypoxemia at nighttime. It creates cardiovascular problems and metabolic disturbances, leading to greater glucose concentrations in the blood. So we know that sleepiness interferes with our ability to function and in our physiological and biological life. Interesting data recently have shown that sleep is important for the elimination of poisons from our brains called beta amyloids. These are from animal data. Sleep is important for the elimination of poisons which build up from the degradation of neurons in our brains. So if we don't sleep, presumably, these poisons accumulate in our brains and cause many of these detriments. So sleep is critical for the well-being of our brains. Let's go on now to talk a little bit about what causes sleepiness in clinical settings. As psychiatrists, as mental health practitioners, what should we be concerned about? What should we be looking for as causes of daytime sleepiness in our psychiatric patients? Well, of course, the main problem is sleep deprivation, not getting enough sleep. We all know that one night of not getting sleep can cause daytime sleepiness, but it's important to also recognize that the impact of daytime sleepiness is cumulative and builds up over time. Here are data on normal subjects showing 1 to 2 or 2, 4 or 6 nights of sleep deprivation. These are individuals who have been completely sleep deprived, no sleep whatsoever, for 2 nights. You can see that they're making many, many mistakes. These are attentional lapses or mistakes, many mistakes. People who are deprived of sleep by only 4 hours, that is, they're allowed to get 4 hours of sleep, are also making more mistakes, but more slowly. So after about 2 weeks, they also start making just as many mistakes as the people who are deprived completely. What's interesting is that the people who are getting 8 hours of sleep per night down here, you can see that they're making more and more mistakes over time. So even getting 8 hours of sleep per night is not enough. 8 hours of sleep per night is not enough. You follow? Is not enough to make sure that we are completely alert during the course of the day. That's not only for our patients, but for us too. 8 hours of sleep is not enough to make sure that you're alert throughout the course of the day in and day out, for the entire course of your life. Now, narcolepsy is another cause of daytime sleepiness. We do not know the prevalence of narcolepsy. Nobody has adequately looked at this. But we think that it's increased prevalence in psychiatric populations. Narcolepsy is a condition which causes recurrent daytime sleepiness and is present in the context of cataplexy, which I'll describe in a second. And this is a sudden loss of muscle ability to control our muscles. And narcolepsy has been linked to hypocretin deficiency. And I'll talk about that in just a second. Here's a patient who has narcolepsy with cataplexy. This is cataplexy. Can you turn the video on, please? This person is laughing, and after this course of laughing, he falls to the floor. He loses control of his muscles. He can't get up. Now he's completely awake, but he cannot control his muscles. Here he is again. He's laughing. Now, narcolepsy doesn't usually present, cataplexy does not usually present in this dramatic fashion. Typically, there's ptosis, or bid lag, head drop, or simply blurred vision. I had a patient who had cataplexy characterized by jaw drop. She was a young woman who was dating, she was 20 years old, and whenever she dated a man who was exciting or stimulating, her jaw would drop. She'd be unable to speak, and she would start salivating uncontrollably. So she stopped dating. She did not want to date anymore until we treated the cataplexy, and she now is married, has 2 children. She did very well. Many narcoleptics also have hypnagogic hallucinations. Hypnagogic meaning on the way to falling asleep, they begin to hallucinate. See very vivid images, usually visual hallucinations, during which many have sleep paralysis. They feel paralyzed. One of the reasons many narcoleptics are not properly identified is that these symptoms, especially in the psychiatric setting, tend to be confused with psychiatric problems. We're confused in this case with psychosis, and in this case with nocturnal panic. So it's important for us as psychiatric professionals to look at these patients and make sure that they're not psychotic. Most of the narcoleptics many years ago, before being properly identified as narcolepsy, were misidentified by psychiatrists as psychotic individuals and placed in long-term care settings. Many narcoleptics go undiagnosed. This is the peak age of diagnosis of presenting of symptoms of narcolepsy. You can see most narcoleptics are presenting in their symptoms at the age of 15 to 19, but the peak age of diagnosis is the age of 30. So there's a 10-year lag between the symptom presentation and diagnosis because their symptoms tend to mimic other conditions. We know that narcolepsy is probably a condition of hypocretin deficiency, or a deficiency of a set of neurotransmitters which are located in the hypothalamus. These neurotransmitters control many other neurotransmitters like the norepinephrine, serotonin, and histamine. And here's a brain of a narcoleptic showing the staining on the right side of narcolepsy and the left side of a normal person, showing the staining of the hypocretin neurons. Sorry about that. Showing the lack of hypocretin neurons in the narcoleptic. Narcoleptics have a high prevalence of psychiatric conditions, primarily depression. This was a study looking at narcoleptics and comorbidly looking at their anxiety disorders and mood disorders. You can see that they have a 2.5 odds ratio of having anxiety disorder and 4.0 odds ratio of having a mood disorder. I have not seen one narcoleptic in my practice who is not also depressed. Not one. They all have depression and are often all confused with the hypersomnic depressive individuals. It's for that reason that I think it's critical for psychiatrists, psychologists, mental health professionals to look for narcolepsy in their patients. Now, we also think that possibly there's a relationship between narcolepsy and depression because of the fact that the orexins may be playing a role in the genesis of depression. Animal models of depression seem to suggest that blockade of orexin receptors induces an antidepressant effect. So it may be that orexins play a role in the genesis of certain depression. The diagnosis of narcolepsy is established with something called the multiple sleep latency test. Individuals are kept in a sleep laboratory, asked to fall asleep during the course of the day or to take a nap. People who are normal fall asleep in 14, 15 minutes during the day. Narcoleptics fall asleep very rapidly and have REM episodes, REM episodes during their nap tests. Narcoleptics have to be, in the treatment of narcolepsy, we have to make sure that they take regular naps, avoid shift work, avoid sedatives such as alcohol, and avoid recreational drugs. And pharmacologic treatment is important for many narcoleptics. Many of the drugs used for narcolepsy are on this slide. The American Academy of Sleep Medicine has indicated that modafinil and armodafinil are standard treatments for narcolepsy. So is sodium oxybate. Guideline treatments, less standard treatments, there's less data backing these drugs, are the amphetamines, methylphenidate, and selegiline, which is a monoamine oxidase inhibitor, is almost never used for a variety of reasons. Now, modafinil is a racemic mixture of two enantiomers, I should say, R and S enantiomers. The elimination half-life of the compound is about 15 hours, but it has the S enantiomer as well as the R enantiomer. The S enantiomer's elimination half-life is short. It's about 4 hours. So the majority of the long-acting the potential of this drug is probably a result of the R enantiomer. Armodafinil, which has been available in the United States for about 6 years, and which will be introduced in Mexico soon, has the longer elimination half-life of 15 hours because it's only the R enantiomer. Now, the armodafinil and modafinil have the same elimination half-life, but because armodafinil is only the long-acting compound, its plasma concentrations are higher at the same milligram value. So its Cmax is 37% higher, and its area under the curve is 70% higher compared to modafinil. And this gives it a higher concentration at the end of the day. So here, for example, are plasma concentrations of modafinil and armodafinil. Modafinil is is number 1 and number 2, the racemic mixtures of S-modafinil, the S enantiomer, and the armodafinil enantiomer. You can see that in general they have lower concentrations than armodafinil, which has a higher concentration, milligram per milligram, at the end of the day. The dosing, modafinil 200 to 400 milligrams in the morning, armodafinil 150 to 250 in the morning, and these are the primary side effects: headache, nausea, dizziness, and insomnia. Both drugs can slightly induce the a CYP2C19 system and 3A4 system, so we have to watch out for decreasing concentrations of steroidal contraceptives and also prothrombin. There's a very rare possibility of serious rash, so you should warn your patients. If you develop a rash, stop taking the drug, call me, and do not take the drug again until you speak with me. And if it's very serious, they have to go to the operating room, to the emergency room. But this is a very, very rare reaction. Stimulants are also sometimes used. Methylphenidate. It's a very good drug for immediate effect. If people become very sleepy, they can take it. It lasts for about 4 or 5 hours, and it wears off. For example, if you need to drive. Dextroamphetamine, single dosages. The racemic mixtures, the mixed salt mixtures of dextro and amphetamine are also sometimes utilized. Methamphetamine is sometimes utilized also. The side effects are headache, nervousness, and nausea. These drugs are a little bit more difficult to use and also a bit more addictive than methylphenidate, than modafinil and armodafinil. Finally, for cataplexy, the loss of muscle control, we use either venlafaxine, duloxetine, or atomoxetine, or the tricyclic antidepressants like clomifene, or the SSRIs like fluoxetine and fluoxetine. None of these have indications for cataplexy, but are used in an off-label fashion. Sodium oxybate was also introduced for narcolepsy. It's a drug which treats not only the sleepiness, but also the cataplexy, and it's used in 4.5 gram doses per night, divided into equal doses. Its effective dosage, maximum dosage is 9 grams. It's a drug which is very strongly sedating, so patients need to be told to stay in bed for that entire time. And its main side effects include, of course, respiratory sedation and sometimes enuresis. It's been utilized for almost up to a year at non-controlled, in a non-placebo-controlled fashion, and seems to have a maintenance of effect which is very impressive. Let me talk a little bit about shift work. Shift work is a problem which accompanies all societies that are industrialized in nature. In the United States, about 4% of the workforce is involved in nighttime shift work. That is, they work at night and they sleep during the day. Many of them go to work early in the morning, 4 o'clock in the morning, 12.4%. And many of them go into work early evening or in the afternoon and stay into the nighttime when you're supposed to be sleeping. And many of them, 2.7%, rotating shift work. So shift work is the working at the time when people are supposed to be asleep. Approximately in the United States, 22 million individuals work shift work. Now, I could not find a paper on the prevalence of shift work in Mexico. Those data may not be available. But in all industrialized countries, most industrialized countries, the data seem to suggest that about 5 to 10% of the population is engaged in shift work. The problem is that some people who do shift work develop a disorder called shift work disorder, where they remain sleepy when they go to work, falling asleep on the job, and they cannot sleep during the course of the day when they come home and they're supposed to sleep. We don't know exactly what proportion of shift workers develop shift work disorder. But when they develop this disorder, many times they come to see us psychiatrists because they can also be depressed, and the sleepiness mimics as depression. In addition, many of our patients who may come to us for depression and anxiety control may be shift workers, and we may not realize it. And because of that, by treating them, we may not be able to get rid of all of their symptoms because of the fact that they have sleepiness as a result of shift work. We also know that shift workers have a higher rate of mood disorders, depression, gastrointestinal disturbances like ulcers, and cardiovascular problems, and stroke, and even cancer. There was a long-term study of nurses, 20-year-long study of nurses, that showed that the nurses who were involved in shift work had a much higher rate of developing breast cancer compared to the nurses who were not doing shift work. Very interesting data suggesting that just altering our sleep in this fashion can lead to strong metabolic disturbances and possibly, because of the inflammatory effects of disturbing our sleep after many, many years may even lead to cancer production. Here we go. We think that the effects of shift work, bad effects of shift work, are caused by a desynchronization of the many biological rhythms that govern our lives. So here's an example, for example, of a person who is sleeping between midnight and 7 a.m. every day. In the triangle is denoted their temperature rhythm minimum, which is a marker of biological rhythms. So this is the temperature minimum, which occurs usually between 4 and 6 in the morning. This is the way this person's sleep is supposed to be synchronized with their temperature minimum. At this point, this person begins to engage in shift work. So he decides to work at night and sleep during the day. Work at night, sleep during the day. Work at night, sleep during the day. The temperature minimum for this person is supposed to be right here. Unfortunately, his temperature minimum stays right there. So this person has now developed a desynchronization by his biological rhythms, right? The temperature rhythm stays where it used to be, but his sleep rhythm is now 12 hours later. And this is happening with all of his rhythms. His mood rhythms, his melatonin rhythms, cortisol rhythms. So this desynchronization between many internal rhythms is what we think causes the negative effects of shift work. This was a study where some individuals who were normal individuals who had some problems with sleep were forced to undergo rotating shift work. After they underwent rotating shift work, many of them developed shift work disorder. The people who developed shift work, the people who engaged in rotating shifts were 5 times more likely to develop shift work disorder and depression and anxiety. These were people who did not have depression, did not have anxiety before, but they engaging in rotating shift work. They were 5 times more likely to develop anxiety and depressive disorders just by doing shift work. You follow? So it's important to remember that when we as psychiatrists speak to our patients, we need to ask them, what is the time of your sleep and what kind of job do you have? Because they may be engaging in shift work, which may be disturbing their mood and mood during the course of the day. Here's an interesting study, which was done by Dr. Van Hart in the United States. So she took a number of normal individuals, and she asked them to undergo shift work, essentially a laboratory simulated shift work, and then brought them back and had them sleep normally. A number of people did not align or did not have their biological rhythms go back to normal. And she examined these people compared to the people in whom the biological rhythms did align. Notice that the people who had engaged in shift work, who did not have their biological rhythms aligned, had a much higher blood plasma concentration of glucose at breakfast, lunch, and dinner compared to the folks who did align. What this says is that if you do shift work, even if you go back to sleep at the normal time, your blood glucose concentration may be higher. And these people also had a higher insulin level, meaning that they became insulin resistant. And this is one of the reasons why people who shift work for long periods of time, some of them become insulin resistant, become obese, and develop diabetes. Now, one of the things we need to make sure that shift workers do, of course, is diminish the amount of sleepiness when they're on the job. So plan napping. I advise all my depressive shift workers to take about half an hour out of their schedules during their work and take a nap. Now, this is not possible with all industrial settings, unfortunately. Not all factories allow this, but certainly for residents, for interns, for doctors who are working overnight, it's important to go for 15 minutes and take a nap. it increases our productivity, it increases our mental performance. We know this from experiments. When we are working at night, during the shift, sometimes bright lights can help increase our alertness and improve our sleep the next day. 2.5 to 10,000 lux, LUX, is the critical value. And when we come home, to make sure that the bedroom is as dark as possible, so that when we sleep, light does not interfere with our biological rhythms. When we drive, people who are shift workers, when they drive, need to be warned that if you are sleepy, pull over and take a nap. In the United States, I'm not sure what the rules are in Mexico, but in the United States, physicians in some states have an obligation to ask their patients if they're too sleepy and if they're falling asleep when they drive. And if they do that, it's our obligation to report their names to the Department of Motor Vehicles, because they are a danger to society. And if we do not report that, and the patient has an accident, we are legally liable for that in some states. However, if we do report, and the patient sues us because their job was taken away from them, we are not legally liable. So we're protected against reporting people to the Department of Motor Vehicles. So some states in the U.S. take this very, very seriously, which I think is important. Because, many shift workers are more sleepy than narcolepsy patients. Now, there are many drugs that we can use to help people who develop shift work disorder, to keep them awake, to help them sleep, hypnotics or sleeping pills, to keep them awake during the job, stimulants like caffeine. Caffeine works. Coffee, tea, it works very well. The problem is that caffeine can interfere with sleep, and I'll show you a couple of thoughts about that. There are also alerting agents like modafinil and armodafinil in the United States are indicated for shift work disorder, that is, people who become too sleepy or cannot stay awake on the job, and they can take these drugs when they go to work. I'll show you some data on this. By the way, going back to caffeine, there are many caffeinated beverages. There are many online resources to find out how much caffeine are in each of these substances. The highest level of caffeine is in Starbucks. Nice. 600 milligrams of caffeine in a Vente, 600 milligrams, very, very high levels, that could interfere with sleep. But the trick is to take 1 cup of coffee roughly for every 3 hours of shift work. Here's some data on modafinil showing that after a few hours, these are at nighttime, between 11 p.m. and 7 a.m., that modafinil increases the alertness level of patients at nighttime, and it wears off after a little bit. So it does help them stay awake. It makes them more alert during the night. Here's some data on armodafinil. You can see that armodafinil also increases levels of alertness compared to placebo in patients during the course of the night between midnight and 8 a.m. So it does work, and with modafinil, there's a suggestion that it does so better than modafinil, although the two have not been directly compared in this fashion in shift workers, but it does suggest that the effect of armodafinil is a bit longer lasting because of the fact that it's the R metabolite. Melatonin at nighttime may also be helpful for shift workers, so not at nighttime, but during their sleep. So when shift workers go home in the morning, sometimes some people advise them to take 0.5 to 2 or 3 milligrams of melatonin to help their sleep, although this has never been shown to actually help them in terms of their alertness when they go to work. Some people have delayed sleep phase syndrome can cause sleepiness in children and insomnia as well. This is a disorder where children have a more difficulty falling asleep at nighttime. This is a person who's falling asleep at 11 p.m. Here's a child with delayed sleep phase syndrome, or an adolescent, who does not fall asleep until 4 or 5 in the morning. In the morning, this person can't wake up at the normal time, but wakes up 4 or 5 hours later. So there's a delay in their biological rhythm. So this kid, this child, his parents actually complain that he is sleepy in the morning. He simply cannot wake up and go to school. This is, by the way, interestingly more common. This delayed sleep phase is more common in children who have depression, especially bipolar depression, this delayed sleep phase syndrome. The treatment for this is morning bright light therapy, when they wake up bright lights in the morning, and evening melatonin. These are the sleep rhythms of this person's delayed sleep phase, and he's being administered melatonin in the evening. Interestingly, the data show that the earlier administration of melatonin, that is melatonin administered 4, 5, or 6 hours before their melatonin, before bedtime, or about 5 or 6 hours before bedtime, is more effective in terms of producing a rhythm change than melatonin right at bedtime. So, many of us are used to giving melatonin at bedtime for insomniacs, but if the person has delayed sleep phase, it's important to give the melatonin 2, 3, or even 4 hours before bedtime to produce the proper sleep phase advance. And so in children who are delayed sleep phase, melatonin should be administered 2, 3, or 4 hours prior to bedtime to be able to produce the proper change in their biological rhythms. Sleep apnea. Let's talk a little bit about that. Sleep apnea also is a cause of daytime sleepiness. Sleep apnea is caused by a collapse or closure of the upper airway during sleep. So instead of the air going into the lungs, it stays in the mouth because the upper airway collapses or closes during sleep. These are some of the major symptoms of people who have sleep apnea. Snoring, right? They feel tired or sleepy. Somebody observes their stopping breathing during sleep, and many of them have high blood pressure or hypertension. Body mass index more than 35 or an age of 50 are also highly predictive of sleep apnea. Neck circumference of more than 40 centimeters or male gender. These are some of the features of an apnea patient clinically that produce a higher risk for sleep apnea. Now, this is something called the stop-bang scale. It's used by anesthesiologists, and 3 of these items or more being positive predict a high possibility of sleep apnea. We use this scale in psychiatric settings, we use it in medical settings. We've published a few papers looking at people in psychiatric settings who have sleep apnea. Right now we're conducting a long-term study looking at inpatient populations with this scale to see if they have a higher proportion of sleep apnea. The presence of sleep apnea produces a high odds ratio, or high risk of various problems like high blood pressure, coronary disease, congestive heart failure, stroke, cognitive impairment, depression, and diabetes. So sleep apnea is a strong contributor to many disturbances, metabolic, psychiatric, and otherwise. This was a study conducted in a psychiatric in sleep apnea patients, looking at the prevalence of psychiatric comorbidities. In blue are patients who have sleep apnea, and in orange are people who do not have sleep apnea or controlled substance. You'll notice that people who have sleep apnea are at a higher risk of having depressive disorders, almost twice the number, anxiety disorders, psychotic disturbances, and even dementia. So the presence of sleep apnea in your population imparts a higher risk for these various disturbances. And this was an interesting study which looked at the 4-year longitudinal development of depression in people who did not have depression to start with, but who did have sleep apnea. So these are people, all of whom have sleep apnea, either mild, moderate, this is no sleep apnea, no apnea, mild apnea, and the right side is moderate to severe sleep apnea. We're looking at the data after 4 years of longitudinal analysis in patients who did not have depression at day 1. So they did not have depression. 4 years later, yes, they did not have depression. 4 years later, we're looking at the risk for developing depression. Notice that the people with moderate to severe sleep apnea after 4 years, had about a 2.6 odds ratio of developing depression. So if you have sleep apnea that's severe, moderate or severe, you have a much higher risk of developing major depressive disorder compared to people who do not have sleep apnea. This is why it's so important for us to look at their apnea in patients with depression. This was a study conducted in patients with post-traumatic stress disorder, PTSD. These people were survivors of sexual assault. Now, sexual assault is something we speak a lot about in the United States these days, for obvious reasons. But these were people who were studied before the current election. Right? You can see that people who have post-traumatic stress disorder, survivors, have a higher rate of nightmares, higher level of PTSD, distress scores, higher anxiety, and higher depression if they have SDB, or sleep disordered breathing. So the presence of apnea increases their post-traumatic stress disorder scale scores. The way to diagnose sleep apnea is to, of course, study people in the sleep laboratory. This is a 2-minute epoch or page from a sleep laboratory looking at the stoppages of breathing here, 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 and here in a person with sleep apnea. This is the only way to diagnose sleep apnea in a sleep laboratory or at the house, in the home, by doing something called home sleep testing. The treatment for sleep apnea, of course, as many of you know, is CPAP, continuous positive airway pressure, with air being introduced into the pharynx, or the throat, to keep the throat open during sleep. Now, CPAP has many advantages. We know that CPAP produces improvement in sleep quality, it improves alertness, it decreases depressive symptoms, it decreases blood pressure, improves heart function, and also decreases mortality rate for people with sleep apnea. I must say that not all of these studies are controlled, randomized studies for obvious reasons. It's hard to do these randomized studies as in patients who have higher risk for mortality. But on the other hand, data with non-randomized studies have fairly well shown the improvement in many of these areas with people with CPAP. This was a meta-analysis of many of the studies that have been done with CPAP in sleep apnea patients, showing the improvement in alertness as assessed by the Epworth Sleepiness Scale, improvement of alertness in patients being given CPAP. We did a study not long ago, actually a few years ago, showing that people who have sleep apnea, unfortunately, don't all stay normal from the standpoint of alertness after they use CPAP. About 40% of patients who do use CPAP still feel sleepy after they use CPAP. And we don't quite understand why this is. But there are now medications which are indicated to treat that phenomenon, or treat that problem. And one of them, of course, is modafinil, and the others are modafinil. And there were a number of meta-analyses conducted looking at modafinil and armodafinil, the improvement of the Epworth Sleepiness Scale score and improvement of the Maintenance of Wakefulness test. Just look at the Epworth Sleepiness Scale score, you can see that in general these drugs diminish levels of sleepiness or improve alertness in patients with sleepiness, which persists after adequate treatment of their sleep apnea with CPAP. Now, there are many alternatives to CPAP in the sleep apnea patients. In the United States, we use a lot of oral appliances. These are also called mandibular advancement devices, which basically pull the jaw or mandible forward while people are sleeping during sleep. Mandibular oral appliances are indicated for mild to moderate sleep apnea. They are not indicated for severe sleep apnea because they don't seem to do as well of a job there. But interestingly, their advantage over CPAP is that patients who use them normally have a better tolerance of the treatment than CPAP. They could use these treatments for longer periods of time than CPAP. There are also a number of other devices, such as the expiratory pressure nasal valve devices. This is a two-way valve, which when placed on the nostril, produces a diminution of the airflow outside of the nostril, producing air to stay in the nose, and this backflow of air opens up the pharynx during exhalation. Surgery is also indicated for sleep apnea as a second-line option. There are many surgeries. When I entered practice of sleep medicine, which was in 1984, after my psychiatric residency, the only treatment available for sleep apnea, the only treatment was tracheotomy. Fortunately, we don't do this very much now. There are many other treatments available. But surgery still remains an important treatment of sleep apnea. In the United States, we've begun to do something called upper airway stimulation therapy. This is also called hypoglossal nerve stimulation therapy. This is a small pacemaker that's implanted inside the skin, which produces a signal which goes to the hypoglossal nerve, which then produces pharyngeal expansion during sleep every time the patient inhales, and inhalation is detected from another probe. This was introduced only a few years ago, and in my institution, Jefferson University of Philadelphia, we've actually done more of these than any other center in the United States and possibly the world. So we see a patient now who's had upper airway stimulation placed, and the pharyngeal diameter, as you can see, is fairly narrow. After increasing the stimulation on this device or turning it on, you can see how the pharynx expands, producing a larger interface during sleep. The indications for this are patients who are above the age of 22, have moderate to severe sleep apnea, and who have failed CPAP, who could not tolerate CPAP, and whose upper airway has a certain type of patency called non-concentric collapse. They also have the body mass index less than 32. And these are some of our data when we had only 45 patients with pre and post data. The apnea-hypopnea index, or the number of apneas and hypopneas per hour of sleep, diminished from 34, which is in the severe range, down to 7. The respiratory disturbance index diminished from 36 to 15. Their oxyhemoglobin saturation nadir increased from 81 to 87. And their Epworth Sleepiness Scale, which is a marker of sleepiness, diminished from abnormal, which is 11, down to 6. So the therapy it works very well. The major side effects include pain at the tongue level, and interestingly, sometimes people have increase in this phobic reaction. We recently did a study looking at the people who came to us seeking upper airway stimulation therapy. And we have not put together the data, but I can anecdotally report to you that most of the people who came to us seeking this therapy, who could not tolerate CPAP, had an anxiety disorder. They had an anxiety disorder. That's the major reason why they could not tolerate CPAP. So I think it's critical for us to make sure, the primary care physicians to make sure, the family physicians to make sure, that they're detecting anxiety disorders in patients who could not tolerate CPAP and treating those. Interestingly, in most of the patients who came to us seeking this therapy, we said to them, we will not treat you with this therapy. We want you to go back and get treated for your anxiety disorder. That's the proper treatment for anxiety. One last area I'd like to talk about as a cause of daytime sleepiness is depression. We know that depression itself may sometimes cause sleepiness. You all know that major depression, the symptoms of major depression, include all of these symptoms, but also hypersomnia is one of the hallmark symptoms of depression. Too much sleep, or retardation, psychomotor retardation, or fatigue, or loss of energy. These are all hallmark symptoms of depression. Many of our colleagues who are not in psychiatry think that the patient who is retarded or sleepy cannot be depressed. But many of the patients who I see, who come to me, who are seeking therapy for hypersomnia, in fact have primary depression, which has been unrecognized by your family physicians. One of the major